So I'll be taking the case studies on how to formulate effective responses. I would like us to recall from the last presentation that the goal of providing drug information, high quality drug information, is not just because we want to give information to a requester, no, but the whole goal is to enhance quality patient care and also to improve patient outcome. So that explains why the structured approach is really very important. And I would like us to also recall that the structured approach entails using 4 basic factors. That's building the database, critical factors, which pharmacist Adekola has just explained. And this generally involves the use of all those 4 critical factors: the patient's information, the medication information, the disease information, and also, of course, of primary importance, the background information of the requester as well as the patient. Then it also involves the analysis and synthesis. Like he said, it's not all the information that you gather that is usually needed. So definitely there must be a thorough review. And at this particular point, this is one of the most critical aspects of drug response, information response, because here your critical clinical thinking skills is important, your problem solving skills is important, and also critical appraisal is very paramount, because you need to really analyze the sources that you get your information from, as well as using the patient's information, the medication information, and also the background information to generate your own judgment or conclusion. Then, of course, the response and recommendations is very important, because the response that you normally might give, definitely sometimes you will have to go behind the question that the requester is asking. So you have to now critically analyze all these factors before you can generate your response. And also the recommendations sometimes might go completely different from the initial question that was asked. Then, of course, the follow-up. The essence of the follow-up cannot be overemphasized. Like he said, it has to be in a timely manner, it has to be quick, and it has to be, because this will assist you to really know whether the recommendations that you made were implemented, whether there was a change in the medication practice or there was a change in the patient's outcome. So I will now proceed now to the case studies properly. Our very first case study, let's assume now you are in the drug information unit, and then we receive a call from a requester asking you the question, what is the molecular weight of enalapril? So of course, if you are going to give a response, which, like we said, high quality effective response should not be haphazard, it should not be given prematurely, because this can also jeopardize the outcome of the patient. So assuming we're going to give a response in the absence of any relevant background information, then our response will probably be like, enalapril is an oral angiotensin converting enzyme inhibitor. One key thing we need to know is that when giving the response, of course, you have to give a brief introduction of the question that was asked. You don't just go in, for example, we won't just go in and just say the molecular weight of enalapril is so and so. No. So generally is required that you give a brief introduction to the question that was asked. So the question now is, what is the molecular weight of enalapril? So if you've not obtained any background information at all, the answer will probably be like, enalapril is an oral angiotensin converting enzyme inhibitor. It is indicated for management of hypertension, for symptomatic congestive heart failure, for asymptomatic left ventricular dysfunction. And then you now go ahead and say the molecular weight of enalapril is this particular figure. However, what we are really doing today is to remind ourselves that this is not the proper way of giving out a relevant and also effective response. Though the response is supposed to answer the question, however, we must note that we have to obtain the background information, we have to categorize our question, we have to understand the true and genuine need of the question. So before we now proceed into giving out our response, the first step that we really must do is to identify our requester. So we need to identify the requester, what's his affiliation, what's his profession, and then we need to also understand what's the true need of this particular question. What is the expectation from the requester? What exactly is he trying to get from us? Then, of course, we also need to understand and also categorize our question. Is it patient specific? Is it related to, is it academic, or is it related to a population? Because categorizing the questions, whether it is patient specific or it is an academic, will also give you a guide as to the time frame for the response. Because if it is patient specific, then of course it is expected that you have to give it, most likely maybe the patient could be waiting, so it has to be prompt and more timely. Whereas if it's an academic question, then you might need to go in depth. So for this particular case study, now trying to gather our information, we now realize that the requester is a basic scientist. So what exactly is this scientist trying to do? He's trying to evaluate the pharmacological effect of enalapril in vitro. So the reason for this question or this query was because the requester wants to know the molecular weight of enalapril for the appropriate calculations for this particular experiment. So not knowing why the question is asked or what the information we are going to give will be used for could be misleading to the requester. So for classifying this particular question, we now realize that it is not patient specific. It is not related to a patient. So of course, we don't need any patient factor. We don't need any disease factor. There is no disease factor related to this particular query. However, the medication factors related to this particular query, we have to do an in-depth research on our query. So for this particular question, the medication factors of enalapril now shows that enalapril is a prodrug, of course, which needs to be converted by the cytochrome enzymes to the active form, which is enalaprilat. So it is converted in vivo. However, our scientists, of course, we said he's trying to carry out this research in vitro. So you see why it's important to get the background information. So enalapril is converted in vivo to enalaprilat, and both enalapril and enalaprilat are commercially available. So these are the information we've gathered about the drug. So how do we now analyze and synthesize our response? Gathering from the information we've gathered, of course, since the query is not related to the patient, it's for an in vitro study to be carried out, meaning that the enzymes, of course, we know cytochrome enzymes are found in vivo. So, of course, definitely it means that this particular drug, if this researcher goes ahead to use enalapril for this particular experiment, then it means that definitely nothing will happen to that particular drug. There won't be any conversion to the active form. So, of course, all chances of him getting the correct result definitely is zero. So, in this case, the question would have been, what will be the molecular weight of enalaprilat, because that is the active form of enalapril, since this research is to be in vitro. So, therefore, to now give out our response, the response will now be like, after assessing everything, after doing a thorough review of our data and information we've gathered, we can now confidently say that enalapril is an oral angiotensin converting enzyme inhibitor, which is indicated for management of hypertension, symptomatic congestive heart failure, asymptomatic left ventricular dysfunction. However, it is a prodrug. So therefore, we need to notify the requester that since the experiment is going to be done in vitro, then because enalapril is a prodrug, if the requester now goes ahead to use enalapril in the research, it's going to amount to a complete waste of time and money, because nothing is going to happen to the drug. So the best thing will be to use enalaprilat, which is now the active form of enalapril, and of course it is available commercially. So in that case, our response now enalaprilat is real, and at this juncture we'll now recommend to the requester to go ahead and use enalaprilat instead of enalapril. So this particular case study now shows us the importance of going beyond just the initial question, as simple as it might be, just the molecular weight. Imagine if we're giving that of enalapril, of course, complete waste of time and money. So for the second case study, now let's say we are also in the office or wherever we are, where I'll give information, and then we receive a call. What's the maximum dose of Oprelvecin. Oprelvecin is a recombinant drug for that's interleukin 11. So what's the maximum dose of oprelvecin? Of course, if you go ahead to give our response in the absence of any relevant background information, we just go ahead and just make our search. We search through our references or our resource materials and just go ahead to give a response. Our response will now be like the recommended dose of oprelvecin in adults is 50 microgram per kg per day, subcutaneous per day, although higher doses of 75 to 100 micrograms per kg per day has been used and studied in breast cancer. And then it was noted that there are dose-dependent side effects such as myalgia, arthralgia, and also cerebrovascular accident event occurred in a patient that took 100 microgram per kg per day after the third dose, and the study was now stopped. So the FDA recommends a maximum tolerated dose of 75 microgram per kg per day. So now this will be a response in the absence of any background information. So as we go through the presentation, we will now see the difference in the response after obtaining our relevant information. That is why we're really going through this presentation tonight. So now, obtaining our background information, we've identified that our requester is a physician. And then why exactly is this the physician asking this question? The question, what is it intended for? What does he intend to use it for? And how will the information we now give now be used? So the question is for a patient who is being managed for human T-cell leukemia or lymphoma virus type 1. And then the oprelvecin was prescribed for the patient's chemotherapy-induced thrombocytopenia because the patient received 4 cycles of chemotherapy using the CHOP protocol. So which is a myelosuppressive chemotherapy regimen. And then as such, the patient developed myelosuppression and had a thrombocytopenia, that's low platelet count. So there is no substantial increase in patient's platelet count was seen after 4 days. So this is the main reason why the requester was now asking this query, because he noticed that after giving oprelvecin therapy for 4 days at a dose, that's the recommended FDA dose of 50 microgram per kg per day, there was no substantial increase in the patient's platelet count. And so he is now requesting, he's now asking, what is now the maximum dose of oprelvecin? He is now intending to increase the dose with the hope that maybe the dose was low, and then with an increase in dose, maybe greater than 50 microgram per kg per day, maybe the platelet count of the patient might not increase. So now this is just the basic information about why the question was asked, and why is he asking it now after 4 days of oprelvecin? Because this is patient-specific question, definitely we will need to get to develop our patient-specific database, and this involves using the patient's data. If you are in a clinical setting or hospital setting, it's easy to get the patient's information once you access the patient's file, or depending on how you now draft your drug information request form, the physician might now input some of this data. And it's very important for us to note that some of this critical and crucial information are not readily available, they're not readily given by the requester. So we must ask probing questions. We need to ask questions in a logical sequence to really gather this particular information. And of course, the fact, if the information is not given, it is not, we shouldn't think that because we were not given the information, so whatever happens, this was the information that I was given or the requester submitted, so of course I've made my response in according to the information. No, it is the responsibility of the pharmacist, who is now going to respond to this query to now extract those valuable information. So for this particular patient factors, this particular patient RR is a 70-year-old male with the human type leukemia virus type 1, and he has been treated with zidovudine and interferon with 4 cycles of cyclophosphamide, doxorubicin, vincristine, and prednisolone. That's the CHOP regimen. And as such, after these cycles of therapy, he now developed severe and protracted thrombocytopenia, which prevented further treatment. Definitely, the nadir has to return back to normal. Of the past medical history of this particular patient show that this particular patient has the human T-cell leukemia virus type 1, adult T-cell leukemia, has cardiomegaly with ejection fraction of 28%, which is secondary to zidovudine and interferon, has peptic ulcer disease, hypertension, and also thrombocytopenia, because it's very paramount for us to get the problem list of the patient while we're trying to now synthesize our response. For the social history, the patient doesn't take alcohol or tobacco. For the current medications of this particular patient, the patient is on oprelvecin, 50 microgram per kg per day subcutaneous, which is the recommended FDA dose. He's on pantoprazole, 40 milligram for ulcer, orally daily. Ramipril for his hypertension, 5 milligram orally daily. Trimethoprim, sulfamethoxazole, double strength, orally daily. On dexamethasone, loperamide for diarrhea, and also acetaminophen for headache. For his allergies, this particular patient has no non-drug allergies. For the lab results, because when we're assessing the patient's factors, we have to assess just as if we're assessing the normal SOAP case notes of the patient. We have to go through the past medication history, the past medical history, the social history, the medications, current medications, the lab results. But that's we're going to go through the subjective and objective data of our patients. So for the lab results, the electrolytes, that's the sodium, the chloride, the carbon dioxide, bicarbonates were within normal range. Liver function test was within normal range. Albumin, glucose, the calcium, magnesium, and phosphorus all were within normal limits. However, the white blood count was high, 28. Of course, it's not surprising because the patient has leukemia. So it's 28.3. Then the hemoglobin is low, and also the hematocrit, 28.1%. Of course, it's not surprising also because, like we said, the person had chemotherapy, so has myelosuppression. Then the platelet count was low. The lowest value was 21,000 per cubic milliliter, and the highest value was 29, as against 150 something thousand. So the platelet count was very, very low, and this is what led to the query from the requester. So what are the disease factors? For the disease factors, we want to try to evaluate whether there's any interaction between the disease factor of this particular patient and the query that is now raised by the requester. So for the disease factors, it is not known whether the patients with adult T-cell leukemia respond differently to oprelvecin than those with other non-myeloid malignancies, because T-cell leukemia is a type of malignancy, and which is also transmitted by blood and all that. So it's a type of malignancy. However, it is not known whether there is any interaction between patients with this particular disease and oprelvecin. So medication factors, we are going to go through that particular medication that is involved in our query, or if it depends, because this particular query is pertaining a particular medication. So that's why we're focusing on this particular medication. But if it is pertaining a particular disease state or a particular condition, then we'll have to go through medications that could be responsible for that particular factor. We might see it later on along the presentation. So oprelvecin is indicated for the prevention of severe thrombocytopenia, secondary to myelosuppressive chemotherapy in adult patients. It is so because, like I said, it is interleukin 11, which is normally given to stimulate a megakaryocyte from the megakaryocyte progenitor stem cells in the hematopoietic pathway. So the approved dose is 50 microgram per kg per day. However, higher doses have been studied in breast cancer patients, but like I said, it was associated with higher incidence of adverse effects, and also fluid retention and cerebrovascular events have been reported at that particular dose. Thus, the PECT maximum tolerated dose was 75 microgram per kg per day, and the duration of therapy is 25 days. This is very important. We should note that the duration of therapy is 21 days, and also platelet counts usually begin to increase between 5 to 9 days after initiation, with peak count about 14 to 19 days of therapy. This 5 to 9 days is very important because our patient, of course, if we recall, the physician noticed no substantial increase after 4 days, whereas platelet counts normally increase between 5 days, not 4 days. So now, to analyze our response, after going through those particular critical factors, going through our evidence, our data that we've accumulated, we now realize that RR has received only 4 days of oprelvecin treatment. And of course, from the medication profile which we just saw, oprelvecin, the increase in platelet counts normally starts after 5 days to 9 days of therapy, meaning the particular days that is normally required to see that optimal response has not yet been achieved. And platelet counts are expected to increase between 5 to 9 days after immunization. Therefore, the optimal response has not been reached. And also, higher doses, yes, they have been used, because the question of the requester was, what's the maximum dose of oprelvecin? Because he has given his patient 50 microgram per kg per day and wants to go higher. So yes, from our search, we've noticed that yes, 75 microgram has been used, and that's the maximum tolerated dose. However, there is serious adverse effects. So therefore, in this particular patient, increasing the dose will just lead to increase in serious adverse effects, of which part of those adverse effects, like we said, fluid retention, cerebrovascular event, without any additional therapeutic benefit. Why? Because the days that is required to see that optimal response had not yet been achieved. So after analyzing everything and we've synthesized our response now will not be like oprelvecin, which is an interleukin 11 and is a hematopoietic growth factor. It's a thrombopoietic growth factor that stimulates hematopoietic stem cells in the hematopoiesis pathway that's towards the for platelets. So it results in increased platelet count. It is indicated for prevention of severe thrombocytopenia in adults with myeloid malignancies at high risk of thrombocytopenia following therapy. So that's after initiation. However, RR has only received 4 days of oprelvecin, and therefore the duration of treatment is insufficient for optimal response. Also, adverse effects, like we said, is dose dependent. So increasing dose more greater than 50 microgram will now increase the risk for those particular adverse effects, and is also not warranted. Therefore, we will now recommend to the physician that he should withhold any increment in dose until these particular days of therapy has been exhausted, to see whether there is going to be any benefit or none before he can now proceed. So for the next case study, if for example, like I said again, we now receive a call, and this particular time around we receive a call asking about drug-drug interactions. And so the question is, are there any drug interactions between labetalol, clonidine, amlodipine, lorazepam, and minoxidil? Of course, if we're going to give our response without any obtaining our relevant background information, we could give a response that would be like, after an extensive search of literature resources, it did not reveal any significant drug-drug interactions between labetalol, clonidine, amlodipine, and lorazepam, and minoxidil. However, concomitant therapy with a beta blocker, alpha adrenergic blocker, calcium channel blocker, and peripheral vasodilator may increase the potential for additive hypotension. Now, this will have been like a response without obtaining our background information. However, like I said, the first step is to obtain our background information to get our patient data, medication, and also disease factors before we can now analyze and synthesize our response. So obtaining that particular background information about our requester, we now realize that he is a physician. It's very important to obtain the information about the requester, because depending on who your requester is, it determines the amount of information you are going to give. And also, because if the requester is a physician, then of course you can go more in depth. If it's a patient or someone else, then you have to tune it down to the literacy of that particular requester. So the question for this particular patient, the question is for a patient with severe hypertension. And why is this particular physician asking this question? Why now? He is asking this question now because after receiving all those drugs, we saw labetalol, clonidine, amlodipine, there is still suboptimal control of the morning blood pressure of this particular patient. So he is now asking this question because he intends to add minoxidil to the regimen while he's trying to avoid drug-drug interaction. So, of course, this is patient specific. So we have to gather our patient database. So going through our patient database, we now realize that our patient SL is a 40-year-old male with severe hypertension and renal insufficiency. And also for his past medical history, He has had HIV infection for the past 5 years, hepatitis C for the past 8 years, hypertension 4 years, and the renal dysfunction. His social history: he takes 1 to 2 pints of vodka daily for the past 12 years. He has used 1 pack per cigarette for 25 years, and also has history of intravenous drug abuse. This is very important because sometimes from the patient information you could link up to why the query is coming up, maybe to synthesize a response entirely. So for the current medications, the patient is on labetalol 400 milligram orally daily at 9 a.m. That means he's on labetalol once daily at 9 a.m. Clonidine transdermal patch 0.3 milligram per day. Amlodipine 10 milligram daily, also orally at 9 a.m. Lorazepam 1 milligram orally as needed for anxiety. He is on multiple vitamin orally, and also doesn't take any complementary or alternative on other non-prescription medications. It's very important to know if the patient takes other non-prescription medications, especially because he's hypertensive. And of course, we know some OTCs, that's the over-the-counter drugs, like some of these cough preparations or NSAIDs, could increase blood pressure. So it's very important to get this particular aspect of the information, that's whether the person is on any non-prescription medications, because it could be the reason for the suboptimal blood pressure. But for in this particular patient, he is not on any of such, so definitely that has been ruled out. So for the allergies, he is allergic to lisinopril. Why is it important for us to get the allergy information? Because when we are making our response, let it not be that we now recommend an alternative whereby the patient is already allergic to. So in this case, the person is allergic to lisinopril, which is also an antihypertensive. So whatever we're going to recommend, we know definitely we can't go on lisinopril or any of those angiotensin converting enzyme inhibitors. So for his lab results, the sodium the remarkable level is for serum creatinine 2.9. Of course, we've already seen that he has renal dysfunction, so it can be expected to see a slight increase in his serum creatinine. His viral DNA is less than 100 copies per mil. His CD4 count is 900 cells, which is good. His blood pressure readings for 3 days, the values in the brackets are for 3 days at 3 different timing. So at 6 a.m., we can see the blood pressure, the systolic at 172 as against the diastolic of 116. Then we can see 178, diastolic 114 at 6 a.m. At noon, well, it's okay. Then at 8 p.m., 158, slightly high. However, from the readings, we can see that the highest blood pressure reading is at 6 a.m. So what about our disease factors? This particular patient has HIV infection, and other infections which we've seen, and it is known whether patients with HIV respond differently to antihypertensive medications. It's very important because HIV itself can cause oxidative stress and several other issues in the body. So, however, doing a search on whether it can affect the antihypertensive medications, there was nothing related to that. So, for the medication factors, a literature site showed that no reports of drug interaction, because if you carry out drug interaction, you can use any of the checkers. None was found between minoxidil and any of SL's current medications. However, the dose of each agent is also appropriate for achieving adequate BP control in the face of significant renal compromise. We shouldn't forget our patient has renal dysfunction. So, like we said, it is patient specific. So you have to individualize your query to your patients that you are really attending to. However, for this particular patient, labetalol was noticed to be labetalol, which is normally dosed twice daily because it has a duration of action of 8 to 12 hours. For SL, he only received 400 milligram once daily at 9 a.m. And if you recall, his highest BP reading was at 6 a.m. just before his antihypertensive medications. So, using our evidence and our data that we've collected, to analyze our response, I also synthesize our response. We noticed that SL's blood pressure was highest at 6 a.m. just before labetalol and amlodipine are administered, which both are administered at 9 a.m. And also from our medication information, we know that labetalol is normally dosed. The maintenance dose is usually 200 to 400 milligram twice daily. However, our patient SL is on 400 milligram once daily at 9 a.m. only. So the observed increase in morning blood pressure could be in part to inappropriate dosing of labetalol. So adjustment of labetalol dose should precede any addition of antihypertensive agent, because before we think of adding up a therapy, we need to optimize the ones that we're already using. Even though this particular patient, we've seen that he has been smoking for a long time and he takes alcohol, but for this particular patient's problem, there is no indication that it is contributing to the patient's problem, which is now the suboptimal blood pressure. So for our response and recommendation, after analyzing everything that we've gathered, we can now respond to the requester that there appears to be no significant drug-drug interaction between minoxidil and SL's current medications. However, a review of SL's current regimen, which showed that he is on labetalol 400 mg once daily at 9 a.m., suggests that the dosing is inappropriate, considering the duration of action, which is 8 to 12, and that it is normally dosed twice daily. So therefore, this could be partly responsible for the observed increase in the morning blood pressure of this particular patient. So we will now recommend to the requester that before initiating or adding any antihypertensive agent to this particular regimen, there will be a need to optimize and adjust the labetalol therapy. So instead of giving it once daily, he should give it twice daily. And then if the blood pressure is not controlled with the optimized labetalol therapy, then he can now proceed to include minoxidil. However, we should also recommend that if minoxidil will be given, then diuretic will be added to prevent fluid retention. This is just an example to show that definitely sometimes you need to go beyond the question. You can, if we go back to the initial question, it's just asking about whether there is drug-drug interaction between those particular antihypertensive and minoxidil. But if you look at our final response and recommendation, we can see that it's completely different from the initial query. Why? Because after analyzing and assessing the true drug information needs of the requester, you can now realize that the main issue there is a therapeutic regimen issue, not just going for the drug-drug interaction. So this shows why your clinical skills is very important, and definitely you need it for making responses. So for our last case study for tonight is a question also that came in: can ranitidine cause thrombocytopenia? Now this is the question that we received. So what will be our probable response in the absence of any background information? We can just go ahead. Like I said, of course, you need to introduce the question initially before giving your response. So the question is on ranitidine. So we can just respond by saying ranitidine is a histamine 2 antagonist, which has been infrequently associated with thrombocytopenia as a rare but readily reversible complication. So the question is, can ranitidine cause thrombocytopenia? So carrying out a research, giving out the information without going through a background, obtaining the relevant background information, we can just go ahead and just give direct answer to the thrombocytopenia that has been reported to be caused by ranitidine. However, like we said, the essence is not just to just give it rapidly or haphazardly, no, or prematurely, but we have to gather our information. So now, gathering our background information about our requester, we realize that the requester is a physician. About the true information need of this particular query, we realize that the question is for a hospitalized patient with suspected Cushing's syndrome who has been hospitalized for the past 80 days. And then the patient now all of a sudden now experienced a rapid decline in the platelet counts over the just last 4 days. So the physician is aware that cimetidine can induce thrombocytopenia. However, the requester now wants to know if ranitidine can also induce the same thrombocytopenia or not, because he is suspecting that probably ranitidine could now be the reason for the acute drop in the patient's platelet counts. So now, going through our patient's case file, we now realize that LB, that's our patient, is a 38-year-old obese woman with type 2 diabetes and is being evaluated for Cushing's disease. She has, from her past medical history, gastroesophageal reflux disease for the past 6 years, and then type 2 diabetes mellitus just for the past 1 year. For the social history, there is no alcohol, there is no tobacco, and also there is no occupational or environmental exposure. This is very important to know because sometimes it might be from exposure, not really from the medication. So, but in this particular patient, there is no environmental exposure that we could link to maybe the cause for the thrombocytopenia. So for the current medications, the patient is on ranitidine 150 milligram orally twice daily, intermittently for 6 years for her gastroesophageal reflux disease. She's on metformin 500 milligram orally thrice daily for the past 8 months for her type 2 diabetes, and is on heparin 1000 USB units per mil. And this particular heparin was included as flushing heparin lock because she was hospitalized. So the essence of including in her medications was just to clear to maintain the patency of the intravenous device, not for any anticoagulant activity. So for her allergies, she's allergic to penicillin. And then for the lab results, the electrolytes, the urea, the creatinine were within normal, albumin, calcium, other ions were within normal, her white blood count was, and liver functions were within normal, her glucose slightly high, of course she's diabetic. So, but the platelet count is where our concern now is at. It dropped from 59 to 81,000 per cubic milliliter within 4 days. That's an acute and rapid drop in her platelet count. So now going through the disease factors, LB thrombocytopenia is new onset because it just occurred within the past 4 days. It also has a rapid decline, not just because it's just a new onset, no, but it also has a rapid decline, dropping from 159 to that particular low value. And then also LB has no readily identifiable medical condition as the probable cause of the thrombocytopenia, because thrombocytopenia could be caused by several other conditions. So however, assessing through her case file, we realized that she doesn't have any linked medical condition to her thrombocytopenia, and she also has no clinical evidence of bleeding or thrombosis. So for her medication factors, because now we're trying to link the thrombocytopenia to her medication, the question by the requester is if ranitidine can cause thrombocytopenia. However, this is now in a patient, so we have to go through everything that is available to us. We can't just pin up ourselves to ranitidine. So going through her medications, metformin from literature studies has not been reported to cause thrombocytopenia in any literature. So of course we rule it out. Now ranitidine, yes, it can cause thrombocytopenia, but it is rare and it's usually reversible, and also it usually develops within the first 30 days of therapy. Whereas, if we recall, she has been on this particular therapy, ranitidine, for the past 6 years. So, of course, well, we cannot completely rule out ranitidine, but begin to look out somewhere else. So, heparin is well known to induce thrombocytopenia. It's one of the most common adverse effects of heparin. It's well known to induce thrombocytopenia, and it is usually developed within 5 to 9 days of initiation. And it is no dose dependent. So irrespective of the dose, whether because the heparin flush lock is just a very low dose of heparin. However, the heparin induced thrombocytopenia, that is HIT, it doesn't really develop based on any dose dependent. And also it has been reported in patients that had even used less than 500 units. Our patient used hundreds of heparin. However, the good news about it is that it usually reverses after discontinuation of drug. So now, analyze what we've gotten from our patients folder, from the disease factors, the medication factors, we now realize that, like I said, we've ruled out metformin. So the two drugs now is ranitidine and heparin. So though both of them, that's ranitidine and heparin, can cause thrombocytopenia, when we look at the sequence of events in this particular patient, like I said initially, the onset of the thrombocytopenia was acute. It was within 4 days of therapy of initiation. It was just within the last 4 days. That's after like 4 days of having hospitalized. So we know that ranitidine induces its own thrombocytopenia within first 30 days. LB has been on it for 6 years. So there's high chances that ranitidine will not be the cause in this particular patient. Then heparin-induced thrombocytopenia is usually acute. It is more common than ranitidine and usually occurs at low doses, including heparin lock flush solution. And for a particular patient, LB, her thrombocytopenia was acute and it occurred within 4 days. So heparin-induced thrombocytopenia is the most likely explanation for LB's acute drop in platelet count. So for us to now synthesize our response and also our recommendation, if we remember, our initial question was, can ranitidine cause thrombocytopenia? Now our response is now going to be like, two of LV's medication can cause thrombocytopenia. Ranitidine-induced thrombocytopenia occurs within first 30 days. It's important for us to give a little bit details to the requester about how we came up with our response, because that will also be a guide for the requester to understand our recommendations. So that is why we're explaining that ranitidine-induced thrombocytopenia occurs within the first 30 days, and LV has been taking it intermittently for the past 6 years. While heparin-induced thrombocytopenia, which is usually more common and has been reported in low doses, including heparin log flush solution, usually occurs acutely within the first 5 days to 9 days of use. And based on the presentation of this particular patient, we can now, based on the presentation of and also the temporal relationship, we can now say that the heparin is the most likely cause of thrombocytopenia in this particular patient. So our recommendation now to the requester would be to advise the discontinuation of heparin, because that's the first step in treating heparin-induced thrombocytopenia. Discontinuing the heparin, because like I said, it's reversible. So however, even after discontinuing heparin, there should be a close monitoring of the patient's platelet count, and also a test of heparin antibodies should be done to establish the diagnosis of heparin-induced thrombocytopenia, and also to guide future therapy so that such shouldn't be repeated in the patient. And then also, like I said, there should be a close monitoring of the platelet count. So if it doesn't normalize after discontinuation of heparin, then other potential causes of thrombocytopenia should now be looked into and they should be considered. So these case studies that I just outlined, the 4 case studies that I outlined, is for us to look at, to see the importance of this whole presentation, the importance of obtaining the relevant background information. So if we look at the initial query from these 4 case studies and the final response and recommendations, we could see a completely different response from the initial question that was raised by the requester. Why? It is because the structured approach now emphasizes that you need to gather all these particular critical information, then evaluate it thoroughly, analyze it critically, and then synthesize your response and recommendation. Of course, follow-up is very paramount. So just to conclude this particular session of the presentation, this is a sample of a drug information request form. So why do we need a request form or a response form? Depending on what you can use it for the response, you can use it for request. That is if you are given now the response in a written form. Sometimes the response might be orally. So now just a quick run through this form. We can now see that this form will now enable us to gather all those particular informations we'll be talking about, because one of the key things is knowing this is what you need, then how do you gather that particular information is very important and vital. So using a drug information request form will help you to gather all those particular informations that is needed to now synthesize your response. So a quick run through of the form, we'll now see that the first aspect is the demographic data of the requester. We need to know the requester's name, the department or affiliation, the phone number, of course, because you need to give a feedback and also a follow-up. Then the profession there, like I said, it helps you to know the health literacy of the requester, to know what relevant information you need to give. Then the initial question, what's the background information? If it's patient specific, what's the age, the gender, the weight, the disease state, what are the medication level is what we've just seen now, etc. Then what's the ultimate question? The difference between this initial question and the ultimate question is what we've just seen in the last 4 cases. The initial question will be the initial query by the requester. The ultimate question will now arise after analyzing all those particular information. What will be the ultimate question? So now it's very important to classify the question. Why do we need to classify the questions? Because you can see classification, availability aid, whatever, identification, general product, a whole list of it. So why do you need to classify the question? This is very important because it helps you to know which resource to now search for your information. Because if, for example, now the question is on availability, then you know where you have to search. because there are different resource sites and reference materials for different information depending on what you want. If it's for adverse effects, you need to go to an adverse effect resource information source. If it's for pharmaceutics, it's for therapy evaluation and all such. So that's for classification. If it's for pharmacokinetic, you don't go looking for a pharmacokinetic information in maybe availability research material. For example, we're very familiar with our MDEX. So for MDEX can help us now, let's say, to check availability, strength, manufacturer of a formulation. Then pharmacotherapy reference books will help us with other maybe therapy evaluation and all sorts like that. Then for the search strategy is important because you need to indicate your source and the utility. It's very important because I think along the line of the whole of our presentations, the other modules will come across the presentation. But for the search strategy, it's very important because of the three resources, the tertiary, secondary, and the primary. So usually for drug information requests, you need to start with the tertiary. Then if you don't get much of the information, go to the secondary, then the primary. So usually start with the tertiary. So it's important to indicate which resource you used for the information, because sometimes there will be need to now go back to check or something. Then what's your findings? What's the response that was finally given? And then the signature and all that. So these are a list of my references. Thank you very much.
That was awesome. Thank you very much, Pharmacist Ruqaiyatu. I'm sure you agree with me. We had a very interesting and engaging presentation. Please, we would like to take your questions. Please indicate by show of hand or you type in chat.
Thank you for the wonderful presentation. Even though I missed maybe a lengthy part of the presentation because I had a clash that was a little bit more pressing for me to attend. My question is from your experience in running a drug information center in a precise and I would say detailed way like this, do you have any funding from your facility? And if you do, funding that you could recommend in terms of maybe a monthly request? Because you were talking about making phone calls and a host of other things, maybe getting to search out the information and all of that. What do you have going on in your DIC that enables what you are able to do effectively in this regard?
Okay. Should I respond after all the questions? Hello?
Hello, good evening.
Yeah, good evening. Can I respond?
Maybe you can first question first.
Okay.
Yeah, good evening. Dr. Bello. Hello, good evening. Dr. Bello, are you hearing me?
Yes, you are hearing me. Please go ahead.
This is Pharmacist Akonde. I just want to ask Pharmacist Ruqaiyatu on the time frame within which we can answer those queries from those people who ask us questions. For instance, you have mentioned some background information about our patients. So if one is in the, what do you call it, drug information office, do we need to go into the ward and evaluate those parameters that pertains to the patient? Because of the time frame that the requester will need the information. That's just the question I want to ask.
On the plot of today's election. Well, the report we got from the field is that there has been substantial compliance with our processes and our procedure. And we are happy that we have made incremental gains in relation to our processes and our procedure. As I pointed out, in over 93%, we recorded at least 93.72% opening on time, and we are happy with that particular issue. in few of the places we didn't have a good statement. But we know what some of the.
Well, we're not hearing, no.
Because we get to the governorship election that we take to get to back.
Dr. Bella, I think she should be answering the questions she has for now, because the time is going.
Okay. So okay, let me answer for the funding and search strategies. How do we do that? Well, actually, a drug information center, if it's within the hospital facility, it's supposed to be funded by the hospital facility. The hospital is supposed to be responsible because, of course, the drug information unit or center, depending on how you want to call it, in any facility, it's supposed to be under that particular facility. Unless if the drug information center is on its own. Then if it's on its own, well, it has to now decide on how it's going to be funded. But if it's under the facility, then the hospital should be responsible for funding all anything that will be involved, especially for the phone calls. It all depends on the policies of the hospital. So for some, because for some people, the drug information center or unit could be giving some funds for that, or it could be given the phone. That's the phone call and the phone, mobile phone or the table phone, whatever you're using. Like for our own facility, the hospital provides the phone. Yeah. So it depends on which facility you are in. But of course, because if you say you're going to fund it, you can't fund it from yourself, definitely. So it depends on the policy of the hospital. For some hospitals, maybe they have external source of funding that I don't know. But if it's usually under the hospital facility, then the hospital facility or the management should at least acknowledge that the unit is very important. So one of the key things that we can do now is we have to show how important that particular unit is or that particular center is. So once they appreciate what you have to do, because the whole hospital is supposed to be for the patient, to improve patient care and patient outcome. So if they appreciate the value, which is what we're doing now, if they appreciate the value of the services that is rendered there, I think they should be able to fund that particular unit. So it all depends on the policy of that particular hospital. Unless if any facility is fortunate enough to be funded by any company or something, well, that's the luck of that particular facility. But all I know is that it's usually funded by that particular hospital. Then for this to enable you get the search, it depends. Like I said, also, like in our facility, we have internet access. So if your facility provides free internet access to the unit, then of course it makes it completely easy. But if the facility does not provide free internet access to the users, it is now at the expense of the user to now, because to carry out evidence-based research, definitely you need internet. Because even though there are some offline apps which you can use, but definitely you need you might need internet, because like up to date, like some of these are Lexicon, which is a very good drug information reference, whether it is Lexicon online or Lexicon mobile app. Unfortunately, it needs subscription. So, but one way you can do is if you download the app, it can give you a 30-day free trial. Lexicon is a very good drug information resource which you can use offline once you've downloaded a database. Then, of course, with making response for drug information queries, usually the first resource you need is a tertiary resource. So if it's tertiary, it might not really be too expensive, because tertiary resources, yes, even though some are online, a good number of them are online for you have like facts and comparison to have updated information. But then you can use your textbooks, your reference books, which will cost you less. So for the funding and what you need for the strategies, it depends on the facility. That's just it. Then for the time frame to answer that particular question, and whether we need to go to the lab, to evaluate the parameter, it depends on the facility you are running. If your facility runs an electronic database, it's very easy, because all you need to do is just obtain the patient number or ID number of the patient, and you just run it. So it makes it easy. So if you're on electronic medical records, well, it makes it very easy and very fast, because you can just log in from where you are, to access the patient's information. But if you don't have that, if you still operate with the manual, that is where it's going to be a little bit more, it takes more of your time. But then using the request form, drug information request form, which I showed at the end of the presentation, will guide you in the sense that you get your query from the physician. So you just ask the physician just some key questions. You get the information from the physician. In this particular case, it's easier to get from the physician than just going through the case file. So you can just ask, let's say, for example, you get a query on a patient. You can just ask briefly, okay, after asking for the demographics of the particular requester, what is profession and all that, just as the person is asking, you can just ask, okay, so the patient, you just ask, as in, just kind of like fast. What's the basic info, what's the demographic of the patient, what's the age, what's the weight, okay, what's the height, what's the condition, you can just ask some of these questions. So it depends. If it's electronic medical records, like our facility, we use electronic medical records, so it makes it easier. But if it's manual, it will really take a bit of your time. But like I said, it depends. If the patient is waiting, then you have to make it a bit timely. You have to try and be fast. That's just it. I can't give you a time range of the time you will need because it depends on the query. But if it is patient specific, then you can't, of course, tell the physician that you get back to him tomorrow. No, definitely it has to be that particular day. You need to work on it. So it will be good if you are more than one person in the unit, so that as one is doing out another one can do something else. But if it's just one person in the unit trying to do all these things, then of course it's going to take more of your time. Then if the question is more broad, then of course it might need an in-depth research and take more of your time. But if it's patient specific, try as much as you can to just be fast. It's just the same way you carry out a pharmaceutical care intervention. You know, when you have a situation that you need to intervene promptly, not after the whole thing has happened. So just the way you carry out your pharmaceutical care intervention promptly is the same way you try to respond to drug information queries promptly, depending on how you now operate in your facility. So I can't really peg down to what time frame you can do